Welcome back, everybody. You know, the syndesmosis has been a controversial area for orthopedics ever since I've been training about 25 years ago. So it's great to start hearing from some of the experts on the latest and greatest on thoughts about syndesmosis. Dr. Gerard Bork from Australia will be leading this and will be leading an esteemed faculty. So, Gerard, it's all yours.
Thanks very much, Dr. Parekh. And I'd just like to thank you for the opportunity to talk on this esteemed meeting, and to thank Ben Forster and Andrew Wines, two of my colleagues, in this discussion. We'll try and cover it as quickly as we can because there is a lot to cover.
And actually, Gerard, I also do want to thank Acumed as well for sponsoring for the event for this hour. So it's all yours.
Okay, none of us get any disclosures there. So we know the anatomy of the syndesmosis with the anterior and the posterior interdistal tibiofibular ligaments, as well as the interosseous ligament. But the other thing that isn't talked about a lot is the deltoid ligament, because in order to have a syndesmotic injury, of course, you have to have a deltoid ligament injury as well. It is a synovial joint, and I think this becomes much more relevant when we talk about screw placement and whether or not you penetrate a synovial joint if you can possibly avoid it. But the other thing is, especially with CT scan, we know that it's a 3D movement. It's not just separation, medial and lateral. It's actually a sliding or an external and internal rotation around the fibula. The other thing that we know from CT is that there's a wider gap posteriorly than anterior, and this comes into relevance when it comes to arthroscopy especially. So we've all seen these diagrams of the anatomy, and here's the actual view here. Traditionally, it's taken 1 centimetre above the ankle, and on the radiological imaging, there's meant to be less than 5 millimetres there and 1 millimetre of overlap on the AP and the mortise view. And this is the corresponding CT view, and you can see that the anterior gap is much smaller than the posterior, and that's the normal situation. These are some of the views of disruption seen on CT scan. This is a newer measurement where the volume of the gap is measured, a volumetric measurement, and I'll talk a little bit about that in the future. But here we can see the AITFLs disrupted, the PITFLs are intact. The interosseous ligament is often more difficult to see, but it's usually inferred. You can see here edema in the interosseous ligament. That's a typical finding and may or may not represent complete disruption. But also look at the deltoid ligament. It's also has some abnormality associated with it. We're not going to talk a lot about fracture today, but obviously it's a common thing to think of, especially in the Weber B fracture, where it's set up to 50% of ligaments in disruption. And you can see here the anterior ligament's gone, but the posterior ligament has not. It's said to be less than 10% of ankle sprains, but I suspect that it's higher and missed more often, 50% of Weber B fractures, and I question whether 100% of Weber C fractures do have a syndesmosis. Often it's delayed, especially if there's no fracture. So there's no good classification system. It's been graded on both duration and number of ligaments involved, and more recently with imaging modalities such as MRI, weight-bearing CT, and dynamic ultrasound. Essentially, at the EFOS conference, I think 5 years ago, there was a classification where it's with and without fracture, and if there's no fracture, then acute, which is less than 6 weeks, is it stable or unstable? If it's stable, treat it conservatively. It's unstable, fix. Subacute, which they didn't really define, repairable versus non-repairable. And again, there was no strict definition of what repairing was. And then the chronic, and again, there was no specific time frame, but it was graded according to whether there was arthritis of the tibiofibular joint or as well as the syndesmosis. The diagnosis, there are historical features that might be suggestive of syndesmosis injury, and Ben will talk about those, as well as the various examination tests. And I'd just like to say I find it very difficult if there's a concomitant lateral ligament injury, which is not uncommon in a patient who just says it hurts everywhere, doc. Imaging is important in the diagnosis. Most people will come in with an X-ray. Weight-bearing views and comparison views are often not initially sought. But there are those measurements that I mentioned earlier. MRI is really the gold standard of imaging at this stage, but it isn't dynamic and it's not weight bearing, which brings us to CT scan. The axial view is the most useful, and you can compare both sides. And then weight bearing CT scan, which is a relatively new modality. I must admit I'm biased because I own a weight bearing CT scan in my own room. So I do a lot of these. I find it a fabulous tool in the investigation of syndesmosis, especially once they can weight bear fully through their foot. You can compare both sides as you can do a weight bearing CT of both at the same time. There's reduced radiation, but it's not readily available in most centres, and it may be difficult due to pain. But there's been a number of new imaging parameters that have been hypothesised, and as yet we're yet to find what is the best type of measurement to determine a syndesmosis injury that's unstable, but it looks like that volumetric measurement is going to be the way. The only thing is that it's very difficult to measure, and you really need an autometric system whereby the machine will do it for you at the tap of a button, and that's still coming. It does also rely on the contralateral side being normal, and there are plenty of sportsmen I know who have injured both sides over the years. And if it is too soon, you can't weight bear after the injury. So really, until we get a normal database, weight bearing CT is going to remain useful, but not the gold standard. Dynamic ultrasound, I must admit, I have no experience with, but you would need to make sure that you have a trusted and very highly accurate ultrasonographer. And the other thing I've found extremely useful is imaging guided local anaesthetic injection to determine whether the syndesmosis is the source of the pain or whether it's other injuries, especially if there's a concomitant osteochondral lesion. Arthroscopy assessment is controversial. At the moment, it's deemed to be the gold standard, but I've always felt that it's more of a silver standard, as the papers that really promote it are self-prophesizing in it. They've decided that there's instability and then they arthroscope afterwards. But Ben will talk more about that. Just note that if you do use distraction during your arthroscopy, that it does result in less at the medial lateral translation, but doesn't change the sagittal AP translation. So the acute injury, if it's stable, will be conservative. Unstable, reduction and fixation, as we know, is screws and or suture buttons and combinations of both. But don't forget direct repair of the ligaments as well as deltoid repair. I certainly, in my registrar days, one of my bosses used to do a deltoid repair, and I was incredibly impressed about how stable the ankle was following that. There's, of course, removal of fixation. Just in a sort of brief scan of the literature that I did, and it's very difficult because there's so much written about this, and so it's hard to know which ones are the best papers. But screw fixation does seem to be more rigid, but it is more likely to result in malreduction. Sutures and screws have the same strength for medial and lateral translation, but the suture button allows for some AP translation micromotion, which may or may not be a good thing. It doesn't matter what you use. When you compress to reduce one of these syndesmosis, you always reduce the volume compared to the uninjured part. Now, no one knows what the result of that is and whether it means anything. And the other thing that's interesting is the ankle position during fixation didn't influence the range of motion post-reduction. I must admit, I always put them at 90 degrees when I reduce and compress them because I don't want to lose dorsiflexion, but it doesn't seem to matter. So when you're using a single button versus single screw, the only big meta-analysis that I found showed that the suture anchor did better, but it didn't have a comparison to two screws. And then there's the controversy regarding chronic, whether you do a reconstruction and what you use or whether you fuse them. I think the other thing that's important is when you recognise that the patient has one of these injuries, that we need to give them the correct information. Do we weight bear them earlier than normal ankle sprains? Is their return to work and sport going to be as quick? And I've certainly heard quoted that it's twice as long as a non-syndesmotic injury. is there a long-term risk of osteoarthritis? And when do we remove the hardware? The only other thing I was going to mention, and again, only because I've got a weight-bearing CT, so I get to look at all my own mistakes. Malreduction is unbelievably common, but I'm not certain that it has a great deal of ramifications, especially once the screw comes out. But that's certainly something that's going to be looked at in the long term. So what I might do is I might hand over to Ben now to give a presentation. Ben? So Ben, if you can share your screen and unmute.
There we go. Right, I'm board. Okay. My thought with this, like syndesmotic injuries is a glad bag of like a difficult sort of topic to sort of kind of cover quickly and get any consensus in. So my thought really was just to give a sort of a précis of really my approach to it. I mean, background really sort of is probably in the sporting sort of group, and there's, let's see if we can just get this going. So my appreciation, I'll skip through sort of some of these original, like these quicker slides, but I think the incidence of this as an injury has increased over time. It's we see it here, like we're Australian, obviously, but the nature of our games here is that the rules have changed. The athletes are getting bigger, faster, and stronger, and as a result, I think we're sort of seeing more in the way of injuries. But the importance lies in it twofold. There's like one is in the short and and medium term. These things will take a lot longer to rehabilitate, and like the implication is that they'll be further time away from sport. But at the long term is that really that we don't want to be leaving these guys, girls with injuries that are really going to come back to haunt them. And as Jared sort of suggested, the management decisions in and around this injuries are not clear. So my thought was to just give you a bit of a précis on sort of how I go about assessing them and making decisions about how we treat them. The history is really important. I think if ultimately what you're looking for is like their description of the sort of like of the mechanism of their injury, they'll report whether there's posterior pain. They'll tell you whether there's a pop. They'll tell you where that initial swelling is. And in a syndesmotic injury, like those things are sort of relatively well localized. So if they've got anterior, like the predominantly anterior pain as opposed to posterior, you can sort of be a little bit reassured that the injury is not as gruesome. Their swelling often tends to be a sort of pop, like an egg, like on the sort of, which is above the sort of normal swelling you should see from a lateral ligament injury. When there's a delay in these coming to you, which there often is because they're sort of, they can often weight bear. Some of them will sort of finish the game out, most don't. But they find that they can sort of progress back to running in their rehab, but just can't push off and certainly can't cut or change direction. So the examination I find like is important. I'm trying to sort of match their sort of their mechanism and their history with what I can sort of find to examine. So that I think there's a point of difference, like when you examine them anteriorly, the AITFL like always comes off on the fibular side, and its insertions above the ATFL. So if you're just careful about where you're sticking your fat thumb, you can usually sort of find like that point of difference in their tenderness. Posteriorly, it's important, and I actually if I'm worried that they're a syndesmotic injury, I'll place them prone, and that just means I can get my thumb into the back of their ankle a little bit more aggressively. And as Jared suggested, the deltoids are really quite important. If you're trying to work out in these which are the low or high grade injuries, and so if the deltoids involved, that's often sort of a bit of a sort of red flag for you. In my hands, that like a prone external rotation test is probably more reliable. I think if I can reproduce their pain, particularly posteriorly with that, then I'm sort of a little bit concerned about what's going on in the posterior elements of it. Usually, like I'll do that with the ankle in neutral initially, but sometimes I'll bring them up into plantar flexion, sort of with them prone. jam up the sort of posterior sort of compartment a bit, and then externally rotate them, and that can sometimes make them jump off the table, and that's often a worry for me. The squeeze test, I think if it's positive, then you really know that you're in trouble. I think it's a good sort of positive, but like often a false negative. And if you've got the facility sort of like to strap them and sort of functionally test them, that actually helps you. I won't dwell on this sort of too much, but like we still see the major nerve fractures sort of appear like with an MRI scan in hand. No X-rays have ever been done. We're in a group really, or in a population really, where we've got a lot of Pacific Islanders playing our contact sports, and those guys particularly will have like widened syndesmotic sort of gaps, like on both ankles. So it's important to have comparison views. Stress views, I'm not the greatest fan of, and I just think it's a bit subjective, and I just can't see that it makes much of a difference to my sort of decision-making sort of process. So, and with regards to CT and ultrasound, there was a vogue for dynamic ultrasound. I think in the right hands, and if you can reliably sort of reproduce the sort of person that's doing it, then that's possibly useful. See the weight-bearing CT, the only one in Queensland's in Jared's office. So, so we probably haven't used that as much up here. Like, Andrew lives in the sort of like the more posh estates, and often they've probably got about 3 or 4 in each room. So, but I use it like it is like if you're worried, like it's a good comparison view. We're looking for anterior subluxation, like that isolated sort of posterior malleolar fracture that you might not see otherwise. If you're concerned, it's actually a useful tool. But MRI scan probably sort of is the one that's easiest for us to get a hold of, and as Jared was saying, you can get a good look at those ligaments. So for mine, the issue really is what's happening in and around the posterior elements. I think the anterior elements are pretty easy to see. The interosseous sort of component to it, we often sort of see, but if you can see changes particularly on the sort of tibial side with the posterior elements, I think then you start to again worry that you're in trouble. And we looked through a group of these that we'd done sort of probably about 3 or 4 years ago. And one of the defining sort of things was this little bit of edema in that on a sagittal sort of T2 in that posterolateral sort of corner. In those, it was a good indicator that there'd been a decent injury to it. And I accept, like Jared's sort of thing, that it's a self-fulfilling prophecy, but it often gives you an idea of really how aggressive that injury's been. So my decision to arthroscope, and I do use the arthroscopy as a diagnostic tool, is a really high suspicion on both their mechanism, their history, but their history and the examination have got to fit with their imagery. So because I think particularly these days, if there's certainly a group of patients that you'll see that their MR scan findings are actually sort of like in excess of what you can see clinically. So trust your clinical judgment with them. Don't operate on the MRI scan. And really for me, the key is what's happening posteriorly, because if we have that intact and we know that the posterior elements are intact, we can be relatively sure that one, the degree of injury is a little bit less, and two, that like we can sort of treat these non-operatively, and still come out with a good result in a reasonable time. So my thought, like grade 2 for me, is that sort of like, that West Point sort of that old West Point grading system. But essentially, if you can just think that's probably the sort of anterior and interosseous sort of components. The importance of mentioning these guys is that there's going to be a crossover if you're using that criteria that sort of I'm using to sort of as to whether or not to arthroscope them. Occasionally these are going to be diagnosed on arthroscopy, and if because you'll be worried, but get in there, find that they're stable, and leave them alone. And if and that certainly happened. You can see changes, like there might be a sort of 5, 10, even sort of 30% sort of injury to the PITFL complex at arthroscopy, but when you probe them, they're stable. You can't sort of make them move. And I'll go through what I kind of use as a rough guide for instability in the next couple of slides. But that group you can come out of, you can boot and treat as you would do, like, for the lower grade syndesmotic injuries, and get them going, and aggressively sort of rehabilitate them. But in that group, like if we looked at a sort of group that 2 or 3 years ago, the arthroscopy in that group really didn't sort of delay their return to play. So in that elite group that sort of you're trying to sort of get back playing quickly, that didn't really influence that. Obviously, we don't want to be operating on people we don't have to be, and so it's just a grey area for us. But what I do in essentially what I'm talking about is the grade 3 injuries. People describe a sort of probe or a drive-through test. Kim Slater, who's one of our more senior sort of surgeons that does a lot of sports stuff, we talked about using the blade of the arthroscopy probe, which is about 3 to 4 mil, and there's a drive-through test with a 4.5 sort of like chondrotome. But I don't think that's the only part to that. I think if you can take what Jared said before, the syndesmosis is closed at like a little bit more closed at the front, more open at the back. And you've got to appreciate that when you're trying to sort of decide whether these things are unstable. So things have evolved for me. I want to see the fibula move. It needs to sort of like open up for me to sort of think that it needs to be fixed. And the issue really is, are we seeing sort of what is normal for that patient? But my thought in that is, if you're doing a lot of arthroscopy in your practice, and you can get a fairly decent idea of what's a stable syndesmosis and what's not, and it's part of my normal sort of sequence of examining an ankle anyway. So I think, for mine, reductions, the other sort of conundrum that people sort of struggle with. There's all sorts of different ways to do this. I've gone to sort of using a pelvic sort of reduction clamp, and but making sure that the sort of tips of those are centered on the sort of the tips of both the fibula and medial malleolus, with the premise being that I'm reducing it along the intermalleolar axis. And if some of the guys will use forced posterior translation, so open it, debride it, and push back. And I don't think that that's wrong at all. I think that you've just got to be sort of happy in your hands that you're sort of you're reproducing what's normal for that patient. So the position of the ankle, you can see on that sort of middle slide of mine, or middle photo, that I do use a traction setup, but we actually release that as we compress. And if but also the position of the ankle, I'm not as, I suppose, not as sort of rabid about sort of holding it at 90 degrees. I think years ago, Hans Zip was sort of talking about it in reduction sort of post-fracture, and didn't notice any change. And then there's been papers since that have suggested that your dorsiflexion range isn't sort of particularly influenced by it. So what I want to do is to make sure that I get it reduced properly. So I'll use a combination of, that's just more setup stuff, but the choice of, I suppose, the choice of weapon in days gone past, and particularly with the big boppers, some of the guys that are 120, 130 kilos, I certainly was using screws and 2 screws in those. But probably over the last 9 or 10 years, my practice has been a combination of screw and tightrope. And I'm not the sort of the greatest believer that the tightrope can provide an adequate hold in your bigger sportsmen, women, and in particularly in the nastier injuries and the higher grade injuries. So I went through a vogue of placing a tightrope and a screw, and then just taking the screw out later on, leaving the tightrope behind. But in that, I found that positioning my screw was sort of difficult if I wanted to leave the tightrope in the right place. But my current regimen is actually to, if I think that the instability is significant enough, I'll actually screw them in the position I want my tightrope eventually, and I'll remove that screw at the 6-week mark, and as a day surgery thing, I'll put a tightrope in the hole. So So I think that like the issues really in and around that sort of that group that you're going to treat and to stabilize is kind of where to fix them. So where do you put your screw? I think it needs to be above the sort of physeal scar, but enough that you're actually sort of you think that you're sort of putting it outside of the joint. But I think that there's so much sort of variability in that pocket of synovium that comes along the interosseous membrane that you've got to sort of have a halfway bet between making sure that you're actually holding it reduced well enough and you've got the device in the position that's going to hold you stable without sort of impinging on your joint too much. So if I use a screw, I'll use a 4-5 screw over 4 cortices and roughly about a sort of centimetre above the joint. I do take the screws out and I take them out early. I've got a group of patients really that sort of are relatively high demand and I need them going. And so that second day surgery procedure doesn't really slow them down too much. They're doing sort of pretty much all they want to do at that point. And usually the screw out sort of is just a sort of like a bit of a bump forward in their rehab. I'm not, I know that there's a vogue. You can leave those screws inside you and let them break. But again, I'm not the greatest fan of that, and particularly in a contact pivoting, twisting sportsman or woman. So that, and I suppose the only other little sort of like thing in that, there's the tightrope orientation. So if we're going to treat all these patients and we think that the tightrope's a relatively benign tool, that's probably not correct, really. I think if over time the orientation of where you're putting that tightrope has changed, and I think if we can think that the orientation of our malreduction is sometimes we're pushing the fibula forward. I'll often sort of have that tightrope sitting a little bit further back than we were probably taught as registrars. That'll avoid my saphenous nerve as well, because I think there's certainly an incidence of that, compression of that or irritation of that, which bothers them. And if the one thing that they do, like in that, particularly when you exchange, they'll get medial pain. So just as a word of warning, if like that, because of the sort of traction against the sort of periosteum at that point, it's just like it's worthwhile warning your patients. So, but the grey area is the equivocal scope. Like what happens when you get in there and you think, oh God, it's a bit unstable, not terribly unstable. Do I fix it? Do I leave it? And I think you've got to take in the factors like that pertain to your patient. So like if if you leave it and treat them a little bit less aggressively in the rehab, give them a bit more time. If you're worried that they're sort of a little bit less stable than you'd like, then you can take that risk. I think if you're dealing with a patient that really their sport is their livelihood, and certainly whether it's right or wrong for me, I'll fix them rather than leave them. And if my experience sort of with a tightrope over time has been relatively good. There's certainly there wouldn't be it'd be incorrect to sort of say that no one's had any problems with them, but on the whole, sort of like that it's been more favourable than the other way. And if and so in that group particularly, I'll look towards doing something for them. So my post-op regimen is to sort of, I do put them in a back slab. They, roughly 2 weeks, but like it gets earlier and earlier as time goes on. They get a boot from week 2 roughly to week 6. We get them weight bearing, touching down at 2 weeks, fully weight bearing by 3. I get a bit concerned about the potential for breakage in the screw. In some of the bigger athletes, I do protect their dorsiflexion range in that first 3 weeks. I think if I think, for mine, that'll come back over time. I'm looking to sort of get that syndesmotic, complex as stable as I can. They can push their proprioception and calf strength through that period and we progress them rapidly sort of through like their functional tests from the 4-week mark. So if they've got a tightrope only, you can probably make the assumption that they're probably the lesser grade injuries or the lesser unstable injuries, if you will. we can get those. We would look to try and get those guys, girls playing back at 6 to 8 weeks. But if they've got a screw in there, that will certainly delay them in terms of their return to sport. But not so much, I think, from the surgical point of view. I think it's more because they're a higher grade injury. Couple of just quick things. We're not talking about fractures sort of too much, but we brushed on this at a meeting a couple of weeks ago. There's current vogue for the anatomical sort of plates to sort of use tight ropes as their only fixation across the distal tibiofibular syndesmosis. I'm just not the greatest believer in that. The plates actually stop you from using sort of like a screw if you're worried. So in essence, for mine, we do see missed injuries both in the sort of like the medium term, but also long term. That central sort of picture here. Obviously, we're too late there, but I do worry about the group on the right with comparisons that have used in a wide syndesmotic gap in a 19-year-old professional soccer player. So they'll have continued pain. They'll still have the same symptoms they had beforehand. I'm with Jared. I think that the use of selected injections into that zone actually sort of help confirm your theory. And in that group, we'll reconstruct them with usually hamstring graft. Obviously, there's been reports of different grafts, be it palmaris longus or even sort of plantaris. I just don't think it's solid enough. So I just use gracilis. I'll openly debride the syndesmosis and reduce it at that point, and actually hold it with a screw above. And initially, and the tunnels really go medial to lateral, and they're quite distal, sort of like pretty much where you'd want the exit of those, the exit of your ligaments. And so you're trying to anatomically reduce the ligaments. And I use a U passage of that graft anteriorly, like from the medial side, anteroposteriorly through the fibula, and then medially again back through the sort of tibia, and hold it with interference screws on the medial side. So that group, obviously there's an element that you could sort of you can move on to sort of fusion, but in the athletic group that are looking to return, I'm trying to sort of restore their function as close to like I think I can get them as possible. Thank you.
Thanks, Ben, for that. So if you just unshare your screen.
Yeah.
So basically, Ben's covered that really well. What I'm going to do now is to just go through each of the things and ask Ben and Andrew their opinion on the various steps. So, Andrew, in the history, are there any historical features that ring bells for you for a syndesmotic injury?
Yep, absolutely. I certainly think the ability to weight bear is an important one. Oh, sorry, in the history, did you ask?
Yeah.
So, yeah, the thing in the history, as Ben mentioned, you've got to ask them exactly how they did it. And certainly the classic one we see is in the rugby sports that we played, where there's a patient that gets tackled by one or two or three of the opposition, and generally their foot is fixed and they're rotated around a fixed foot. And often there's video of it actually happening in the elite athlete, and every mum and dad these days seem to have a video of their kid playing every single moment of sport. So often they come in, and it's the classic one for the syndesmotic injury is a rotation around a fixed foot, and if you ask closely, often they can describe that quite well.
The other one, Ben, is often, I get a patient who comes in at the 4 and 5 week mark and they just haven't progressed with physio. Do you think that's a red flag?
Yeah, man. Again, and you go, I think that's really common actually. And if and it's either been that like Andrew is sort of saying, that mechanism has kind of been missed. That it's such a different animal to like a normal lateral ligament sprain. You know, we all know that the kind of supination sort of adduction sort of injury can give you a syndesmotic sort of problem. But often if you go back and talk to them, the mechanism's completely different. They haven't progressed. And yeah, they're certainly the group that you'd look for. If, and that's, I mean, again, go back to first principles, exactly what we're sort of saying. You start assessing them from almost the ground up again.
All right, Andrew, you're only allowed to do one examination test. What is it?
If I only had to do, if there was only one, I would grab their fibula and I would see if I could pull it forwards and backwards. And if it moved and it hurt, I'd be pretty suspicious.
And for Ben, you're the external rotation test. I'm the external rotation test. I must admit that clearly that's not in real life. You're only allowed to do one. So, but as the medial lateral test, I think if that one there I've found to be unreliable. It's too general.
Yeah, I agree. It's like pretty hard to see. Like, it's hard to feel any difference. And like, yeah, I don't know. They can be positive for a whole bunch of reasons. So
yeah. So Andrew, I do happen to know that there are not weight-bearing CTs in every room in Sydney because there's only about 3 in Australia. But what are your go-to investigations?
Yeah, so I mean, first of all, is a weight-bearing plain radiograph. I mean, I think you know that gives you a lot of information, and certainly, and I always get bilateral weight-bearing X-rays. Obviously, they need to be able to weight bear they need to be comfortable enough to get a weight-bearing X-ray, and it needs to be a proper weight-bearing X-ray. So, if they can't weight bear, then getting a weight-bearing X-ray is a waste of time, and can actually, you know, give you negative information. So the importance of a weight-bearing X-ray is that they are able to weight bear. But bilateral weight-bearing X-ray, I think, can give you a lot of information in the more subtle ones. And certainly that's my first investigation. If I'm then suspicious of a syndesmotic injury, because of the relative availability, I'll go to an MRI scan. And I think that gives tremendous information. And I think Ben's point there about the bone marrow edema in the posterior malleolus or the fracture that you haven't seen on your plain films is a red hot pointer. Well, it gives you the diagnosis. And you know that if that's there, then almost for sure there's a syndesmotic injury. But you can quite clearly see the anterior and posterior ligaments on the MRI scan. So a combination of a weight-bearing X-ray and an MRI scan is my standard set of investigations for, you know, the ones that you can't diagnose on a plain film. I mean, let's not forget you can diagnose a lot of syndesmotic injuries on just a plain film. You don't need anything more. I can see the value though in a weight-bearing CT here, and particularly looking at that volume between the distal tibia and fibula. You know, I can see value in that. Because it is weight-bearing, it is dynamic. It has some advantages over the MRI scan, but I don't have a weight-bearing CT, so I use plain films in an MRI scan. I've certainly never used a dynamic ultrasound, and I can't see the point if you've got a weight-bearing plain film in an MRI scan.
Yeah, the weight-bearing CT I think will be good. It's really good in the future whereby if you've got a sort of subacute situation, you know, 6 or 8 weeks, and you're not sure whether there's instability. And my protocol is to do weight-bearing CTs non-standing, so non-weight bearing, and then I get them to stand up, and that way you can compare left and right as well as the weight-bearing and non-weight bearing condition of the affected one.
Hey, Gerard, we have a question. How often do you see chronic ankle instability associated with syndesmotic instability, and what do you guys do for those kind of cases?
Ben, perhaps you want to answer that?
Yeah, I suppose the answer to that is that if the chronic instability is first, if that makes sense, if you know, because the mechanism or the injury patterns are fairly different. So, but in that group, that I think even on one of those slides you'll see there was a guy there with a syndesmotic injury with a tightrope in it, like with a, you know, with it all sort of, oh, actually that's in the next talk. But essentially, like, my thought is they like usually they'll be chronically unstable, and syndesmotic injury comes almost secondary to that. I don't know that they're not the same animal. That's, I suppose, is my thought. If syndesmotic instability and lateral ligament instability are two different animals.
I would agree. They're almost not quite mutually exclusive, but it's a coincidence. Andrew, if you could answer that question, but also what's the arthroscope in your hands? What role does it play?
In my hands, it plays no role in diagnosis of syndesmotic injury, because I don't know what their normal syndesmosis is like, because I'm only doing one side. So I would very, very rarely base my management. In fact, I have never based my management on the arthroscopic findings. I think in the vast majority of these, the diagnosis before you do the arthroscopy. Certainly we had quite a good paper at one of our recent meetings where about 30% of patients having arthroscopies for reasons other than syndesmosis had what you would call an unstable syndesmosis, with the probe being able to driven up through it. So I don't use it. If I go in there knowing if I need to fix a syndesmosis or not need to fix a syndesmosis. I've never had a case where I thought I was going to fix a syndesmosis and I got in there and did a scope and the syndesmosis was stable. Now, I mean, that could happen. I agree, but I don't use arthroscopy as part of my diagnosis. I've never changed putting in a tightrope or a screw on the basis of the arthroscopy. I've always known what I was doing beforehand.
Yeah, I'm amazed that there hasn't been a paper by one of the very big arthroscopists saying our last 1,000 arthroscopies for osteochondral lesions, this is the syndesmotic findings, and they can give what is the normal. Because I'm with you, I don't know normal. So we saw how Ben reduces the syndesmosis. Ben, you don't ever reduce you don't overdrill the fibula the way we were taught, 20 years ago to reduce the syndesmosis. You just use the four cortexes for the stability.
No, mate. I think mine. I think I want to know, because I think that's where I run in the risk of spitting the tails out the front. You know what I mean? I think if I kind of want to know it's sitting right before I'm just fixing it in position. That's so the screws, fully threaded, sort of goes across the four cortices, and so I've never done that. No.
And Andrew, how do you reduce?
I use a malleolar reduction Forster, and then get a picture to make sure, image intensification picture to make sure that I'm happy with my reduction, is how I do my reduction. And then from a fixation point of view, I tend now pretty much always use the suture buttons now. I haven't used a screw for quite a while, even in the displaced ones, even in the big footballers, your 120, 130 kilo footballers with displaced injuries. I've now gone pretty much exclusive to suture buttons, and I've been happy with those. I very rarely only use one. In the vast majority of cases, I'll use two. And I think that just gives you a little bit of extra insurance for, the suture buttons. I think are interesting because for those of you who have ever taken them out, when you take them out, they're not that rigid. There's quite a lot of motion around the suture button. So I do kind of wonder how it works, because compared to when I used to put in screws that were rigid, there is a big difference. And you see that when you take them out. But I've been happy with my reduction and using two suture buttons in the vast majority of cases these days.
There was a paper I read whereby divergent suture buttons have the same rigidity as screws, but if they're parallel, they don't. Do you deliberately place them parallel, or you just put them where they fit?
Yeah, I'm not good enough to drill two parallel tunnels anytime. So every one of mine are divergent. So maybe that's why they're so strong.
Hey, for the entire group, a question: how do you confirm the syndesmotic screw has not over tightened the syndesmosis? Does Taylor tilt provide any insight into that?
In my experience, they all over tighten, and there's nothing you can do about it. I CT every one of them because, as I said, I've got a CT scanner in my rooms, and I just try and make it look normal on the fluoroscan on the table. Ben?
Yeah, a bit the same. I mean, again, I'll go back in and reprobe them for what it's worth. But if and I mean, I suppose sometimes you worry, but I don't actually think that I haven't sort of put it this way. Even if we are over tightening them a bit in that initial sort of phase, then I don't know that translates to anything nasty from a clinical point of view down the track. If that makes sense, I think. That's usually, if I can see that it's kind of sitting right, then I'm pretty happy.
Andrew, Taylor tilt, and I take it by that means that the deltoid ligament's completely gone. If you saw Taylor tilt on the table, would you then open up the deltoid and do a repair, or you just splint them in the neutral position and knowing the deltoid's going to repair itself?
Yeah, I think in the vast majority of those, if you have them with the ankle plantar flexed, when there is a deltoid injury, you'll see that Taylor tilt. But as soon as you put them up into a neutral position, it will reduce. So as long as it does that, that to me indicates that there's not something that's stuck inside the joint. So if I had the ankle in a neutral position and there was still Taylor tilt, then I would have grave concerns that either my reduction was not as good as it needed to be, or there was some potentially some material medially inside the joint, and that would be an indication for doing something to the deltoid ligament. But in the vast majority of these, once you actually put them into a neutral position, that Taylor tilt is no longer there. So as long as you then make sure that your back slab is at a neutral position, then I think it's reasonable not to repair the deltoid ligament.
So we've seen Ben's post-operative regimen. What about yours, Andrew? Is that different in any respect?
Pretty much similar. So I'll have them in a back slab just for a couple for 10 days or so, and it's really just for wound healing and wound rest. I have had a couple, particularly of the sort of the elite athletes who want to get going, not through my design, but they come back for their first post-op checkup, and the club physiotherapy has already taken them out of the back slab and got them walking in a boot, and it doesn't seem to have caused too much trouble. So generally 10 days back slab, crutches, touch, weight bearing, then into a walking boot, weight bearing is tolerated. Once the wounds have healed, I'm happy for them to start some non-loading exercise. So happy for them to get into a swimming pool, do some swimming, walk some laps. Happy for them to get on an exercise bike at low resistance. Happy for them to start on a rowing machine at low resistance. Happy for them to start some light weights at the 10-day, 2-week mark, but all very much within the limits of pain. I don't specifically limit their dorsiflexion, but I certainly don't get the physios to push it too hard. And then I'm happy for them then start some loading activity around about the 4-week mark. But again, what I've found is that it is quite variable. I think the key to the rehabilitation for these is not to go too hard too soon, and they need to be very cognizant of pain. If the physios are pushing them through pain too quickly, then I've found that their recoveries are longer. Whereas if they start loading, but it's within the limits of pain, then a return to sport, at the 6 to 8 week mark is possible. I mean, I think the bottom line with these, how quickly they get back to playing sport is probably got nothing much to do with your surgery. It's got a lot to do with what the original injury was. You might be helping them a little bit, but, the ones that get back really quickly to playing weight-bearing sport are probably the ones that actually didn't need the surgery, in my opinion. But I'm happy for them to load relatively early, but within the limits of pain. And I would expect them to get back to, full activity, full, return to the level that they are at. And the other thing that I think is an observation that I've had with syndesmotic fixation and now with the advent of the suture button is it's extremely uncommon. In fact, I've never seen a patient who has tight ropes in to ever have a syndesmotic injury again. So I think they're actually quite protective of further injury, which for the elite footballer is actually something that's quite important to them.
All right, we're getting on to just quickly the salvage then. Oh, sorry, we'll go back. Just the salvage. My history of reconstruction has been very dismal. So I'm now a fuser, and I'll basically just fuse them. But I don't have the elite athletes that you guys deal with. Do you reconstruct? And if so, what criteria are they? Just quickly, Ben.
Well, I mean, I think it's like if you know that there's like you can document the injury, like so they've got a chronic instability. You like I do inject them. I think it's a good idea. You got to make sure that the pain that they're getting is coming from there. And if you can demonstrate that they're unstable sort of through there, like the longer ones, I'll even use a bone or a spec scan for it. You just got to make sure that it's an isolated injury to that. If it is, and you know that sort of you're on the right track, sort of from the symptoms point of view, then I'll reconstruct them. Usually, sort of in that athletic group, there's a group that are barn door, and then there'll be a group that are sort of like pretty subjective, and it's just trying to prove that their pain's coming from there. And so, but in the like younger athletic population, yeah, certainly I'll reconstruct rather than fuse.
Hey guys,
Andrew?
another question coming through. If you don't have a weight-bearing CTs like you do, Gerard, a lot of us are just relying on fluoro and X-ray. So how much do you guys rely on the dead straight lateral view to judge your reduction, or do you look at that at all and you're really looking at a mortise and an AP?
Andrew?
I rely entirely on the mortise and the AP. I don't get a lateral view in theatre at all.
No,
On the
me
same.
either.
Yeah, I'm the same. It's just AP and mortise, really.
Mortise.
Yeah.
So, Andrew, do you reconstruct?
Yeah, but I think the key is to be certain that the syndesmotic instability is the cause of pain. And certainly I go looking pretty hard for other pathology because I think it's chronic syndesmotic injury relatively uncommon. So I certainly need to exclude that the pain is not coming from elsewhere, and particularly the ankle itself, and whether or not that needs to be dealt with. I've never done a fusion, and I've done a handful of reconstruction, so I don't have a big experience with it. But I think reconstruction is not unreasonable, but it's not. It's not bread and butter stuff. They're pretty uncommon, I reckon.
I think the fact that none of us have done many shows that whether you use a screw or a tightrope, it's a good operation and it solves the problem. I'd like to quickly present a case study. This is a patient of mine. He's a mid-30s club footballer. He lives 3 hours from where I work. He injured himself 3 months earlier and took time off, in typical fashion, just battled on. He came to me a few weeks out from his grand final and he was still a bit sore, but he had been able to return to training. He wasn't tender over the ankle and could hop on the affected leg and had a negative external rotation test. But you can see on my weight-bearing CT, there's an avulsion flake. He's got a widened syndesmosis, AITFL, PITFL have gone. What do you do with this guy now 3 weeks out from his grand final?
3 weeks out.
And he can hop.
Yeah, mate. If he's 3 weeks out from his grand final, let him play. Let him get through that, and then sort of and make it. If he's mid-30s, his wife will retire him pretty soon anyway. And so but if he wants to play again, then you've got to work out really whether or not his ongoing pain's worth what you might do to him. So, but I'd let him play. I don't think it's going to change the outcome one way or the other for him. I have injected those before. Like you can use it as a trial to try and work out whether his pain goes away. But
Andrew,
I'd be very happy with him playing, and then I'd have a discussion with him after the grand final, see how sore he was, see what his aspirations were, and decide whether or not he needed something You know, and again, a little bit might, would be what he wanted to do and what he was allowed to do. As Ben was saying, if he wants to keep on playing, then I don't think it's unreasonable to fix something like this that's out of position, but I don't think it needs to be done acutely.
So I did what you did. I injected him, let him play, and he won the grand final. I then didn't hear from him until midway through the next season, where he got about 3 games in, and he did a sudden injury, which is exactly the same. What do you do with him now, given he's got an acute on chronic syndesmosis injury? Do you repair him or reconstruct him? I don't have imaging, sorry.
Mate, personally, like if he's in his 30s and if and he's kind of turned a chronic injury into an acute one, I'd probably just treat him as an acute injury initially, because the difference in doing that as opposed to a hamstring reconstruction is so huge, and his symptoms have sort of been borderline. So I'd give him a run for his money.
Andrew?
Yeah, I've got exactly this situation in an outstanding full rugby league fullback, and this was exactly his story. And it had sort of 2 or 3 syndesmotic injuries of various grade, and then he'd had sort of one early on in the season, and I scoped him and put in 2 tight ropes, and he hasn't looked back. He's never had another syndesmotic injury, and I would have no trouble with fixing him.
All right, fabulous. All right, well, look, I think we're almost up to time. Thank you very much, Ben and Andrew. Selene, I don't know if you have any other questions for us, and hopefully we've covered some of the difficulties in syndesmotic injuries.
No, actually, you guys have been fantastic. Thank you for the expertise. I'm getting a lot of feedback with the discussion. People loved it, so really appreciate you guys lending some of your insight and experience. Thanks to all of you. Thanks to Acumed for sponsoring the session, and we'll be back in about 2 minutes.
Thanks very much, everyone. Have a good one.
Thank you. Enjoy the midnights.